Today's video, we're going over clinical examination of ACL injuries. Gah! My name is Dan Pope. I'm a physical therapist and a strength coach. We've helped to make thousands of incredible clinicians and coaches through our online courses, communities, and mentoring programs. The goal of today's video is to make you 1% better. So getting an accurate diagnosis for ACL injuries is very, very important because about 50% of folks have a complete ACL tear will go on to get surgery. So if you're missing these clinically, you're maybe missing a chance to have the right intervention for your patient. So like any other ligament injuries, these are graded on a 1 to 3 scale. A grade 1 would be a mild injury, a grade 2 would be moderate, and a grade 3 is complete. And the complete ones are probably the most important that we just don't want to miss. So what population are these injuries most common? Generally speaking, you're going to see it in field sports that require pivoting and cutting. So the big ones are going to be soccer, football, basketball, as well as downhill skiing. Another population where ACL injuries is very common is going to be in females. Can males have this? Of course they can. Just a little bit higher prevalence in female versus males. From a subjective standpoint, what are these patients going to tell you when they walk through the door? Generally speaking, the event is going to be traumatic. Usually these are non-contact, meaning that an athlete was cutting, pivoting, changing direction. They may or may not feel a pop within their knee, and usually there's going to be some immediate swelling. Around 70% of folks will have swelling after this injury, but the important thing to keep in mind is that I've diagnosed a few folks, no swelling whatsoever. They did have a complete ACL tear. So that does happen from time to time. Carey in 2018 published some subjective variables that increase the likelihood of your patient having a complete ACL tear. The first is, upon initial evaluation, 3 to 4 weeks after the patient has had their initial injury, they should still have some pain. So basically, if it's a bad injury, complete ligament injury, usually it takes a lot of weeks for this pain to start to die down. Folks with a complete tear of the ACL generally didn't get hurt by falling on the knee. Normally, the injury occurs during a pivoting maneuver. These folks will generally say that right after the injury, it was impossible to continue playing their sport. They have an injury that's bad enough that forced them to stop. And the last one is immediate effusion after the injury.
Hey there, sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video.
Anterior drawer test. Now to do this appropriately and get a good reading, we have to check the integrity of the PCL first. We're looking for a posterior sag sign. So what we do is we palpate the distal femur on the uninvolved side, go down until you get to the joint line and cross over and feel the tibia. And we do the same exact thing on the involved side, find the distal femur, going down, cross the joint line, feel for the tibia. You should feel the same side to side, right? Next thing we can do, so do a posterior drawer. And the thing is, if there's any laxity with the PCL, when I do my anterior drawer, there's not going to be increased anterior translation, but because there's increased posterior translation, it seems more lax on the involved side. So you have to rule out that PCL pathology first. Next thing is the actual anterior drawer test. So we bend the knee to 90. I'm going to sit on the patient's foot, try to get them to relax as much as possible. And from here, I'm going to draw the tibia anteriorly towards me. And the angle is going to be important. So I don't want to pull his tibia straight towards my stomach. I want to pull at the angle of the joint. So essentially, I grab here, and I'm going to be pulling upwards on an angle straight towards me here. And if there's more laxity on the involved side versus the uninvolved side, that'd be a positive test. And if your patient is having a really hard time relaxing, you just do this. You take your phone out, go to the Fitness Pain Free channel, say, hey buddy, Gavin, I got this really cool channel. It's called Fitness Pain Free. I want you to go through, just have a good time, like, comment, subscribe, here you go. And then while they're distracted, you go ahead and just crank on this thing. Lachman test. So essentially, we're gonna have our patient here, Gavin, lying on his back, nice and relaxed. We're gonna take the knee, we're gonna bend to around 30 degrees. I'm gonna take my top side hand, grasp the femur, bottom side hand, grasping the tibia. What I'm trying to do here is stabilize the top side hand and draw anteriorly. And what I'm looking for is increased laxity on the involved side versus the uninvolved side. That would be a positive special test. Lever test. So essentially you have your patient lying on their back. I'm gonna take my fist. It's gonna go right underneath of the patient's calf, just like so. And then my top side hand is gonna go on the femur. What I'm going to do is drive down on the patient's femur, and what you should see is that the heel pops up. If the heel pops up, that's a sign that the ACL is intact. If the heel does not pop up, that'd be a sign that you have a complete ACL tear. Pivot shift test. I'm gonna take the patient's foot and I'm gonna twist him into internal rotation of the tibia. From here, I'm gonna apply a valgus force, my top side hand, and with the valgus force and tibial internal rotation, I'm gonna go into knee flexion. A positive special test would be a subluxation of the tibia. So essentially it looks like the tibia kind of clunks out to the side. Now I tend not to perform this too much clinically. I feel like I get enough information from the prior 3 tests, from the Lachman's, anterior drawer, and the lever. And if at that point I'm suspecting that person has an ACL tear, I'm just gonna refer him to the surgeon. But if you're still kind of curious and suspicious, you can give this one a shot because it still has decent specificity. So Colwyn in 2023 did a study, and what they found is that in patients that were deficient with their ACL, if you had a positive Lachman's, positive anterior drawer, and a positive lever test, you had a 100% specificity for picking up these ACL tears. So clinically, if all 3 of these are positive, you have a good chance the person has a tear of the ACL. From a differential diagnosis perspective, if the patient comes in, they just had an acute traumatic injury, the knee is swollen, it could be an ACL injury, could potentially be a meniscus injury, could be some sort of cartilage injury. It's a little tough to differentiate between the different ones. I think the big takeaway is if you suspect any of those, you're gonna send back to the doctor anyway for some imaging. But from a testing perspective, one way to differentiate between a meniscus injury and something like an ACL would be to try to palpate the joint line. And if you have joint line tenderness, it could be a sign that you have meniscus pathology. And if you have joint line tenderness, pain with end range extension and flexion, but negative ligamentous test, we're starting to think more meniscus pathology. Just keep in mind, ACL injuries as well as meniscus or cartilage pathologies, they're going to hurt with end range extension or flexion likely. They're also both likely to have joint effusion. So just because someone has these things present doesn't necessarily mean you have either an ACL or some other type of injury. And like I said, if you suspect any of these, you just send out to the doctor anyway, figure out what the heck's going on inside the knee. And if you want some more information about how to diagnose meniscus tears, I have just the video for you, Gavin. Leave that link in the corner, go ahead and click on that, and we'll go over clinical examination of meniscus pathology.